Bismillahirrahmanirrahim. Assalamu alaikum. Thank you very much for joining us today. We'll try to discuss the palpation for physiotherapists. This is my brief introduction, and we'll briefly discuss about myself. So I'm a physical therapist by profession and serving as an assistant professor right now in Shifat Amir Millat University Department of Rehabilitation Sciences. Currently, I'm enrolled in PhD in physical therapy at Tehran University of Medical Sciences, and with the passage of time, you will come to know more about me. I'm also a clinician, and I'm sitting in two clinical settings. One is max rehab, and another is aqua shoulder rehab. So first, we need to discuss some basics. So these concepts are the prerequisites while performing the palpation or in order to understand the palpation. Now, palpation literally means to examine or explore by touching. So it is sometimes called as or referred to as seeing through your hands. It is used as a diagnostic aid. It can help you to establish or confirm your diagnosis. It is an art and skill which involves locating a structure. You need to find out where the structure is, becoming aware of its characteristics, what type of tissue you want to palpate, and assessing its quality or condition so you can determine how to treat it. So sometime if there is inflammation, you can find signs of inflammation, and you can find edema, and you can find tenderness over there, and pain and things like that. But in a normal healthy tissue, you won't find such things. And if there's pain, of course there will be accompanying myospasm, which means that the muscles will be taut and they will be very hard to palpate. Palpation requires receptive hands and fingers. So, because I told you earlier that it is seeing through your eyes, so sometimes you have to see through your eyes, listen through your ears, and you need to be quiet at mind and you need to take calm breaths. This is really very important in a society like Pakistan, where we are living. Like Robert Anthony Mackenzie once said, that palpation is not anathema. So it is not a cursed thing. Basically, this is very important if you are trying to make contact with the opposite gender. Of course, introduction of touch is really very important. And being a clinician, you have to be very careful while you want to palpate somebody of the opposite gender. So you have to develop your fingers and your senses in such a way that you need to make as little contact as possible but as maximum as necessary. When palpating, you may want to close your eyes, because if you close your eyes, sometimes you can focus more, so you can enhance your awareness. Now, as you can see in this picture, basically there are two hands that are shown over here. One is called the contact hand and the other is called as uh, the enforcement hand or the top hand. Basically, this underhand is just to make contact with the patient, while the upper hand is for applying more of a pressure. Sometime you need to use thumb as well. So these are different parts of the hand that you can use to palpate any particular region, because the carpal bones are very small. So if you're trying to palpate any smaller structure, you need to palpate with your thumb. If the surface area is large enough, for example, in this picture you're looking at the pelvis and the sacrum, one can use one's entire hand to palpate the larger structures like sacrum. Often the excitement of trying to locate something you search so earnestly that your mental and physical awareness begins to diminish. So sometimes you try to find something and then you start to lose control. Frustration arises, your breath stalls, and your hands ultimately become insensitive. So you begin to work hard. By working hard, I mean that you sometimes press a bit harder, which is not very important in palpation, because I must quote Ida Rolfing over here, because she said that it's not how deep you go, but it's about how you go deep. So palpation is really very similar to this. It's not about how deep you go, it's about how you go deep. So you need to stay calm, and you need to lose all the tension in your hands, in your bodies, and in your mind as well. You need to work smart by first locating the structure you wish to palpate on your own body surface, and then you can palpate it on your partner. Self-palpation will improve your kinesthetic understanding of what you're looking for. Basically, it gives you a very good idea how much pressure is required and what kind of touch is more comfortable. It's always okay to make mistakes. I always tell my students that you are bound to or entitled to make mistakes. So try to be patient with your learning process. Allow yourself to make a wrong turn and get lost. Less is more. Sometime you don't have to jump over the tissue and press it with the entire force of your hand. You can, again, I must say, you can palpate things very gently. As you begin exploring the body, you might not be able to assess things as readily as you wish. So it is sometimes difficult because of different body compositions. Someone can have different fat tissue, someone can have different skin thickness and sensitivity of the skin. So it is always variable to subjects. A common reaction is to press harder and deeper in order to find something. If we don't know how to palpate effectively, what we do is that we keep on pressing way too much hard, that instead of palpating a structure causes pain. So it's always necessary to apply as minimum pressure as possible. Gentle contact will allow your hands to be sensitive, while excessive pushing only numbs the fingers, so making for an uncomfortable experience for your partner and for you as well. Sometimes you have to roll and strum like the strings of the guitar. So you can roll a tissue, you can find out, this is very important if you are palpating smaller structures, and if you are trying to palpate the taut bands, very similar to when we are trying to palpate the taut band for the finding of a trigger point. So when outlining the shape or edge of a bone, try to roll your fingers or thumb across rather than along its surface. This is similar to checking the sharpness of a knife by sliding your finger across the blade. Do the same with the ropey fibers of the muscle tissue, especially again if there is myospasm, you can do this. And like strumming the strings of a guitar, this method will help you to ascertain muscles fiber direction and tensile state, and this will be really very helpful if the muscles are in spasm already. There's a very simple exercise that can help you increase your tactile sensitivity and palpatory skills, and you will need a phone book or any dictionary or any large book that can help you, and a few human hairs. So lay the hair beneath a single page of the phone book, close your eyes and palpate through the page trying to locate the hair. When you find the hair, reposition the hair and add another page. Continue to add pages until you can no longer locate the hair. So how many pages can you palpate? 5, 10 and 15. It will depend on your experience. It will depend on your practice. So the more you practice, the more tactile your hands will become. So this is the representation that you need to randomly open the dictionary or the phone book and place a single hair, and then close your eyes, put a page over it and try to find it, and then you need to keep on adding the pages and moving the position of the hair. Movement and stillness. So this can also help you. If a structure you are palpating is stationary, move your hands across it, or if it is moving, you can stay still. For example, in this picture you can see he is just trying to palpate the coracoid, the tip of the coracoid, and is palpating with some sufficient pressure, and he's trying to roll his thumb. Movement can also help you to palpate a lot of structures. These movements will help you to verify the location of the structure as well as any changes occurring in the tissues as a result. For example, if I recall this movement supination and pronation. So if you want to grasp the head of the radius in a pinching grip, then you can easily feel the rotating head of the radius. So this is a movement as a palpation tool. In this picture you can see active movement, there can be passive movements, and there can be resisted movements. So the purpose of these movements is just to establish uh, a boundary between different structures and to find out a single particular structure. Active movements, they are always performed in a relaxed way. They help you to locate muscles and tendons. It is especially for the contractile elements of the body. It also helps you to differentiate between contracted and relaxed muscles because of different tones. This is a very interesting fact that an adult has over 600,000 sensory receptors in the skin, more nerve endings than any other part of the body. The fingertips are amongst the most sensitive areas with about 50,000 nerve endings every square inch. The fingertips are so sensitive that a single touch sensor can respond to a pressure of about 1 over 1400th of an ounce, the weight of an average housefly. So we all can feel the weight of a housefly on our fingertips. So the purpose of adding the slide is to help you understand. Sometimes you have to put as little pressure as like shown over here. These three principles, what I call as the golden three principles of palpation: always try to move slowly, haste only interferes with sensation. So take your time and then try to palpate the tissue. Avoid using excessive pressure, less is truly more, and focus your awareness on what it is you're feeling. Now, of course, you need to establish a few things in your mind, whether you are trying to palpate a muscle, whether you are trying to palpate a tendon or a ligament, or whether you are trying to palpate a bone or a blood vessel or any other thing. So these different structures, of course, we will try to differentiate between these structures when we will practically discuss this. So all of the above mentioned structures, they basically have different feelings. So they have different responses to pressure and they have a different characteristic feeling. So when you press any particular structure like a bone or a muscle or a tendon or a ligament or even a blood vessel, you can clearly, even with your eyes closed, can tell that yes, this is a bone, this is a ligament, this is a muscle, or this is a tendon, or this is something else. The round robin, this arrangement of people is called as the round robin. So this is really very important. First you need to palpate your partner, a person who is normal, so you can establish what is normal. And when you are about to palpate somebody with some pathology, then it is really very easy to differentiate between the normal and the abnormal. Now we'll briefly discuss the regions of the body. So these are the regions of the body. This is the cephalic region, this is the trunk region, or this is the caudal region, this is the dorsal as well as the posterior region, the anterior region or the ventral region, the abdominal, the thoracic, the lumbar, the gluteal, the thigh, the upper arm and the forearm, hands, wrist. So these are different regions of the body. So the skeleton is divided for the purpose of understanding only, and biomechanically it is divided into axial and appendicular skeleton. The skeleton that you see in the red color is called the axial skeleton or the midline skeleton, while the appendicular skeleton, the word appendicular is taken from the appendages, so it is the appendicular or the suspended skeleton that is articulating with the axial skeleton. And there comes the function of the girdle. We have two shoulder girdles and two pelvic girdles. So the purpose of the shoulder and the pelvic girdle is that it helps to articulate the axial skeleton with the appendicular skeleton. So this is the mechanical linkage between these two types of skeleton. So you need to remember this: the midline skeleton is called the axial skeleton, and the peripheral skeleton or the extremity skeleton is called as the appendicular skeleton. Here you can also see the appendicular skeleton in the red and the axial skeleton into the white. Do you know that the skeleton makes up about 15% of the body weight? The bones are composed of half the water and half solid matter, and it contains nearly about 2 pounds of calcium and more than a pound of phosphorus. Now this phosphorus is enough to match to make at least about 2000 match heads. And although the average adult male is nearly 6 feet tall, if his arteries, veins, and capillaries were strung together, they would stretch about 317 million feet long, or 60,000 miles. So this is enough length. Ants and bees, they both revered for their intelligence and diligence, but they have roughly 250 and about 900 nerve cells, respectively, in their entire bodies. You will be surprised to know that humans, they have, I think it's 100 trillion nerve cells in the brain alone. Now this is the first region of the body that we will discuss according to the palpation perspective. First of all, the topographical views, or sometimes referred to as the naked eye view. You can see this is an anterior view, or taken from the anterior side. We can clearly see the clavicle, or this is also referred to as the beauty bone. We can see the contours of this is upper trapezius, and this is called the cervicothoracic junction region. So you can see the contours of the upper trapezius, and part of the levator scapulae also contribute to it. On the shoulders, this curve of the shoulder is made by the deltoid, especially the anterior, middle, and posterior fibers. The anterior and the middle fibers can be seen over here, or the portion of the fibers can be seen. This is the pectoral region, and this is the bicep brachii region, and then this is the elbow region. This is a lateral view. In the lateral view, there are again a few structures that will overlap. You can clearly see the upper trapezius, you can see the deltoid, the tricep can be seen, the bicep can be seen, and you can also see the pectoral muscles as well, the axilla, latissimus dorsi, and the serratus anterior. The serratus anterior is very prominent while performing this abduction or elevation of the shoulder, and it has different finger-like projections. This is a dorsal view, or the posterior view. We can clearly see the occipital region, the superior nuchal line can be seen over here. The upper trapezius fibers can be seen. The spinous process is not very clear, visible over here, but we can have an idea, rough idea about the spinous process of C7. Spine of the scapula can be seen over here. Again, the inferior angle, the medial border. The spinous processes of the thoracic vertebra can be seen. Part of the latissimus dorsi, the tricep, the deltoid, and the same muscles can be seen. But if a person is a bit fatty, then I think you cannot see or differentiate between these structures. It is really very important to explore the skin and fascia. You will be surprised to know that different regions, they have different thickness of skin. For example, the palmar surface of your forearm or the ventral surface of your forearm has very thin skin, whereas your dorsal surface or the dorsal skin of your forearm is a bit thick. So different parts of the skin, different parts of the body have different thickness of the skin and different fascias. You need to explore them, and definitely we'll discuss with practice. And you'll also surprised to know that in the midline, if the person is lying prone, in the midline you will find the fascia attached. So over the spinous processes, they will be very little or no mobility of the skin and the fascia in medial lateral direction or right to left direction, while there will be some flexibility in craniocaudal direction. Over here you can see in this position, uh, at about 90 degree of abduction, the, the pectoral tissue is really very relaxed and it can be pinched. But as you try to progress towards more elevation, then this is hard to grasp. When a person is lying in supine position and relaxed position, this part of the trunk or the chest has greatest skin mobility in all directions. Now we'll discuss the bones of the shoulder and the fore and the arm. Here you can see the bones that are colored in red are the bones of the shoulder. So the clavicle, it is the only long bone that lies horizontally. Then we can see the irregular bone, which is the scapula, and we can also see the humerus. So these are the typical bones that, or the characteristic bones that make the shoulder girdle and that contribute to the shoulder joint as well. This particular region, the glenohumeral joint, is termed as the shoulder joint, whereas this hole is called as the shoulder girdle. Now this is an important fact to remember, that the clavicle is the first bone to start ossifying in the human fetus, yet it is paradoxically the last to completely develop. Often it is not developed fully until the late teens or early 20s. The scapula, in this picture you can see the anterior view of the right scapula. The scapula has two angles, three borders, glenoid cavity and spine, and acromion and coracoid. So I will repeat and I will try to share my pointer to the position. So first of all, this is called the superior angle because this is the point where it is being curved. This is called the medial border. This is the inferior angle, and this is called the lateral border. On the lateral border, there is a cavity which is called as the glenoid cavity. Below this glenoid cavity, on the lateral border, is something, a tuberosity, which is called as infraglenoid tubercle. And then we have a supraglenoid tubercle. These are the attachment sites for different muscles. Like for example, the supraglenoid tubercle is an attachment site for the long head of the bicep. Then the coracoid process, it is also an attachment site to various muscles, and it is very palpable in almost all of the patients or almost all of the subjects. Then the acromion is also very palpable. It is very prominent part of the scapula. Basically, this acromion is the continuation of the spine of scapula. This is the dorsal view or the posterior view of the right scapula. Again, we'll try to recall all the borders and the angles: the superior angle, the medial border, the inferior angle, the lateral border, infraglenoid tubercle, the glenoid cavity. The acromion is continuous with the spine of the scapula, and if we are talking about the spine of the scapula, it divides the clavicle into the supraspinous fossa as well as an infraspinous fossa. So again, these areas are very important because this is the area where the supraspinatus muscle is found, and this is the area where the infraspinatus, teres minor, and teres major, latissimus dorsi, there are a lot of muscles that are crossing in this area, and this medial border again is really very important. You can find rhomboids major and minor, the middle trapezius, the lower trapezius, and a lot of muscles that we will discuss. Talking about the humerus, it is one of the long bone in the body. There are, you can say, about 3 to 4 very important features that are very important features clinically as well as anatomically for palpation that you need to remember: the greater tuberosity or the greater tubercle, the lesser tuberosity or the lesser tubercle, and the intertubercular groove. Then you have head of humerus, which is all of these structures are very palpable, or the parts are very palpable. The shaft of the humerus, and then there is this tuberosity, which is called the deltoid tuberosity, because all of the fibers of the deltoid is multipinnate muscle, but it is also some sort of fusiform. So they become uh, attached to this particular site, and this is the very same reason it is called as the deltoid tuberosity, and it is very palpable. Then this is the shaft of the humerus, and on the lower end towards the elbow, you can find the lateral epicondyle or the lateral condyle, medial epicondyle and the medial condyle, which is called as the capitulum and trochlea. And you can also see the coronoid fossa over here. There is a bit of debate about this coronoid fossa, that whether it limits flexion or not. So in lean persons, this coronoid fossa, similar to the olecranon fossa, limits the flexion. And then we have the radial fossa on the lateral side. This is the posterior view of the right humerus, and you can see the head of the humerus, the greater tuberosity of the tubercle, the deltoid tuberosity, the shaft, and groove for the radial nerve can also be seen over here. It is not very easy to palpate, but yes, it is present on this bone. And this is the olecranon fossa, that that is the site for the olecranon process, that is part of the ulna, that fits over here, and it limits the extension. And this is the medial epicondyle, the lateral epicondyle, the trochlea, and the capitulum. And then there is the groove for the ulnar nerve. And just to remember this, that ulnar nerve is called as funny bone. The view of the clavicle, you can see the superior view taken from above and the inferior view taken from below. It has two ends, the acromial and the sternal end. This is just very easy to remember, that the acromial end is flat, more of flat, and the sternal end is more of straight and square. So it is not a straight bone, it is curved, and it is divided into medial one third, medial two third, or lateral one third. So again, you can clearly see the sternal end, the acromial end, and this is the whole body of the clavicle. These are all the structures that we already discussed: the spine of the scapula, the medial border, the inferior angle, then we have the superior angle, the lateral border, and the infraglenoid tubercle. On the dorsal side, we have infraspinous fossa, the supraspinous fossa, and the subscapular fossa, which can be seen on the previous slide. If we go back to the other slides, we can find this is the subscapular fossa. So this is the side that is attached to the ribs. Then you can see the acromioclavicular joint, the acromion, and the clavicle, making the acromioclavicular joint, the sternoclavicular joint, and you can see the coracoid process and the deltoid tuberosity. The humeral head has two hills and a valley. This is again very important clinically, because in patients where there is bicipital tendinitis, this is the site you need to palpate for the tenderness and irritation of the long head of the bicep. The long head of the bicep, it passes through the intertubercular groove, and then it gets attached to the supraglenoid tubercle above. And it is a very important stabilizer of the glenohumeral joint as well. The spine of the scapula is very prominent, it is very easily palpable, and it is an attachment site for the posterior deltoid and the middle and lower fibers of the trapezius as well. You can easily palpate the medial border. Sometime, if you ask the partner to lie prone and take their hand behind their back, so it elevates the medial border, and then you can easily palpate it. And sometimes you ask them to squeeze the shoulders or the scapular blades together, so it makes the scapular medial border to become more prominent. The inferior angle is palpated similarly over here. It is shown the partner is in prone lying position, and you can literally try to pinch the inferior angle of the scapula. The superior angle is a bit hard to palpate as compared to the inferior angle, but again, if you first you need to take please remember this fact: if you want to palpate any part of the scapula, try to move your fingers or start from the spine of the scapula, because this is the most prominent point and this is the site where you'll try to start. Then you'll move towards the medial border, and then from the medial border you'll come towards the top and find the superior angle. There's this condition called as the winging of the scapula. Basically, this is due to the weakness of the serratus anterior muscle most of the time, but sometimes it can be due to the hyperactive the pectoralis major and minor, because if the pectoralis major and minor are more taut and they have more tone in them, then what they do, they tend to pull the scapula towards the anterior side, and it gives a characteristic appearance of winging of scapula. Sometimes people believe that there is an injury to the long thoracic nerve, but clinically it is sometimes contrary to this statement. There is some degree of scapular winging normally present with scapular abduction. For example, when a boxer throws a punch, the glenoid fossa is facing anteriorly. In order for this to happen, the medial border must shift posteriorly away from the rib cage. Otherwise, the person cannot make a punch. If this winging of the scapula did not occur, the glenoid fossa would not move anteriorly and the boxer would be flat on the canvas in the first round. Then the lateral border is very easy to palpate, because this is the region, it has very little muscle mass over here, and it is an attachment site for teres major and teres minor muscles. Infraglenoid tubercle, because of its close proximity to the glenoid fossa, it is sometimes very hard to palpate it, but with some practice you can easily palpate it, and it serves as an attachment site to the long head of the tricep brachii muscle. This is how you try to palpate. Again, I must request you to start from the spine of the scapula, go to the infraspinous fossa, then move to the lateral border, and from the lateral border try to go as proximal to the glenoid fossa as possible, and then roll or strum your thumb and you will find this tubercle. So this tubercle is more of a bump. So when you are trying to move or strum your thumb, you'll feel a bump, and this will be the site which is called as the infraglenoid tubercle. Then infraspinous fossa, here you can see it is being isolated. All the area that is in between the spine of the scapula, the medial border and the lateral border is called as the infraspinous fossa, and it is again very easy to palpate, because when you press a bit deep you can easily feel this infraspinous fossa of the scapula and the overlying muscles as well. Then we have the supraspinous fossa. The supraspinous fossa is a bit more muscular as compared to the infraspinous fossa because of the presence of the upper trapezius and the supraspinatus. So, but it is very easy to palpate in, because you need to start from the spine of the scapula and just move a bit anteriorly, and the soft portion that you see over the spine of the scapula is the supraspinous fossa. Then we have subscapular fossa. Subscapular fossa lies deep and it is underneath. This is the reason it is a bit hard to palpate, and you need not to exert too much of a pressure while trying to palpate the subscapular fossa, because it becomes more painful when you apply more pressure. So it is an important attachment site for subscapularis muscle and the serratus anterior muscle. Although the serratus anterior muscle is not attached to the subscapular fossa, but it is in close vicinity to it. Here you can see the therapist or the palpator is trying to palpate. Uh, when you abduct the shoulder to about 90 degrees, the benefit of this position is that it clears off the scapula a lot. So it moves the scapula from this medial position to the lateral position, and it opens up the area, the medial area. So there is more space or room for palpation to palpate on the medial side as well as on the lateral side. So from the lateral side, this is one approach that you can palpate through the subscapular fossa or to the subscapular fossa using your thumb. This is another way of palpating the subscapular fossa using your fingers and trying to lift, but this is possible only in the skinny patients. The acromion is easy to palpate because it is just a continuation of the spine of the scapula. You run your fingers or thumb just a bit lateral and then you'll find the acromion. It's very important to remember that this area is very important clinically. The space between the acromion and humeral head is called the subacromial space, and it sometimes occupies the largest bursa of the body, that is subacromial subdeltoid bursa, and which is sometimes inflamed, and a tendon of the supraspinatus. So this is a very important site clinically for the physical therapist, because most of the shoulder pathologies, they arise because of the pathology in this region, and you need to palpate it uh, quite often in almost every patient coming with the complaint of shoulder pain. The clavicle is really very easy to palpate. Here you can see the sternal end, the and the acromial end, and this part is an attachment site to the sternocleidomastoid. It has sternal fibers as well as the clavicular fibers, and over here this part is an attachment site to the muscle of the neck, which is called as the platysma. We'll discuss that muscle in the muscles of facial expression, and this under area is attachment site for some part of the pectoral muscles. The acromioclavicular joint is really very hard to palpate sometimes because this is a very leveled type of joint. But when you ask your person to move into internal and external rotation, it influences the scapula, and then you can feel a bit of wobbling in the joint that help you differentiate between the acromion and the clavicle. And this is also a very important site clinically because acromioclavicular joint arthritis is really very common. It is very notorious, and it is one of the hardest joint of the body that can be injected to. Then sternoclavicular joint. This joint is sometimes it can have a disc inside it, and sometimes it is without a disc. So again, it is always advisable to ask your partner to move into shoulder elevation and depression, or shrugging of the shoulder can be done to feel the movement of the sternoclavicular joint. Coracoid process is again very important part because this is the site of attachment of short head of bicep and coracobrachialis, and also you'll be surprised to know that this is this is towards the very same direction in which the glenohumeral joint injection is being injected into the shoulder region or the glenohumeral joint. So there is an approach which is called the posterior approach, and that is directed towards the coracoid process. And in the diagnostic musculoskeletal ultrasound, you also try to find the coracoid process, and a lot of muscles that slide under this coracoid process sometimes can cause pain. So if you, for example, subscapularis is very important muscle that passes underneath this coracoid process. So first you need to palpate the coracoid process, and then below the coracoid process you can easily find the tendon of the subscapularis, and if it is painful it means that there is some sort of pathology. Of course the purpose of the palpation is to establish the normal versus abnormal. You can see the different attachments. The pectoralis minor tendon is attaching over here. The coracobrachialis and the bicep tendon are attaching over here. Then you can see the coracoacromial ligament, and you can also see the coracoclavicular ligament. So the coracoid is a very important attachment site. Greater and lesser tuberosities. If you want to palpate the greater and lesser tuberosity, you can palpate it on yourself as well, on your partner, on your friends, and on your patients very effectively. The movement is just internal and external rotation of the shoulder, and you need to find the heel and the depression and again heel. So two heel and a depression is the greater and lesser tuberosity, and this is the most prominent site in the humerus. And clinically it's also very important because again in palpating the long head of the bicep, you first start by palpating the greater tuberosity. As I told you earlier, that this distance between the acromion and the humerus is called the acromio-humeral distance. In a lot of patients, when there is some pathology, you can clearly see a decreased space, and there is potential space almost as thick as your finger or thumb is, about you can say 1.5 centimeter to 2.5 centimeter about. So this site is really very important clinically, and just lateral part of the shoulder you can find the greater tubercle. Here you can see that the therapist is moving external and internal rotation, is performing external and internal rotation, and keeping the thumb at a particular point, and you can see over here the greater tubercle or tuberosity, the intertubercular groove, there is a depression, and in this groove lies the long head of the bicep and then the lesser tubercle. One important clinical point that I need to tell you right now is sometimes uh, there is a tendency of the bicep long head to displace from the bicipital groove, and if there is this tendency that the bicipital groove is not deep enough and it is shallow, it causes a lot of pain clinically upon every external and internal rotation, and there is also a characteristic sound, and the patient can report you about something as if some cord has moved away and moved inside. So this is called the bump, ditch, and bump. The muscles of the shoulder and arm are again very important to palpate, and they are very important clinically as well. The trapezius is divided into upper trapezius, the middle trapezius, and the lower trapezius. Although in anatomical terms we call it as whole of the trapezius, but clinically we divide the trapezius into upper, the middle, and the lower. So the upper is all the trapezius that is from above from the spine of the scapula. It is termed as the upper trapezius. The middle is from the spine of the scapula till the mid of the scapula. This is called the middle trapezius, and below that is called the lower trapezius. You can see the deltoid, the infraspinatus muscle, the teres minor, the teres major muscle, tricep brachii, latissimus dorsi can be seen, and these are the serratus posterior muscles. There are muscles over here which are called as the serratus anterior muscle. You can also see the teres major minor over here very clearly, and the infraspinatus muscle. It is again important clinically that infraspinatus muscle has three bellies. So this is different than the supraspinatus, because the supraspinatus has only single belly, while the infraspinatus has three bellies. And over here you can see the rhomboid minor, which is above, and rhomboid major, which is below. Then you can also see the levator scapulae. Levator scapulae is very close or just underneath the middle fibers of the I'm talking or about these fibers, the medial fibers of the upper trapezius, and there is the location of the levator scapulae, and then we have the deep spinal muscles called the splenius. In the lateral view, these are the finger-like projections of the serratus anterior. If somebody is taking forced inspiration, this is also a muscle of accessory inspiration, or accessory muscles for inspiration, so it helps in inspiration. So you can clearly see the serratus anterior muscle in the lateral view, and latissimus dorsi is maximally exposed, and latissimus dorsi is in continuation with the thoracodorsal fascia as well. The deltoid can be seen, the bicep, the brachialis, the tricep, and the rest of the muscle can be seen over here. In the anterior view, we can again see the deltoid anterior fiber, the middle fibers. We can see the bicep, and the coracobrachialis is not shown over here, but there is this underneath is the coracobrachialis, the pectoralis minor, the pectoralis major, and the levator scapulae and the trapezius. So all these muscles from the anterior side can be palpated really very easily, and they are very important contributors to the shoulder joint mobility as well as shoulder stability. These are a few muscles that we not need to discuss in detail, but we'll just go through these slides. For flexion, we all know that muscle they work in pairs. So one muscle is a prime mover or agonist, while some muscles are antagonist to it. Then some muscles are synergists and some muscles are fixators. So agonists are termed as prime movers. Antagonists are the muscles that are opposing the action of agonist, and then we have synergists. The synergists are the helping muscles that help the agonist, while the fixator muscles are all the muscles that stabilize the bone of origin of agonist. It is important to remember that in different movements, different muscles they work differently. For example, if bicep is a prime mover or agonist in in elbow flexion or shoulder flexion, then it becomes an antagonist in elbow extension. So the muscle keep on changing its function depending upon the muscles, depending upon the movement that the person is performing. Again, you can clearly see the muscles of abduction. The muscles are highlighted, and I can say that at this point you should be able to at least highlight the area of the muscle. For example, this is for the deltoid, and this muscle is the supraspinatus. For adduction, you can see the latissimus dorsi, the part of the tricep, the pectorals, and the other muscles. Similarly, lateral rotators can be seen, the posterior fibers of the deltoid and infraspinatus as well. Latissimus dorsi and rest of the muscles, the upper trapezius, the levator scapulae can be seen, and the depressors are the lower fibers of the trapezius and serratus anterior muscle. Again, these are the muscles for scapular adduction, for scapular abduction, for upward rotation of the scapula and downward rotation of the scapula. The deltoid is a very important muscle, and it makes a lot of bulk of the shoulder region. The most lateral part or the lateral contour of the shoulder is because of the deltoid muscle. It has three fibers: the anterior, the middle, and the posterior fibers. And this is the deltoid tuberosity where it is attached. So this is whole of the origin, and this is the insertion of the deltoid. Now, I always insist my patients to perform active movements if I want to palpate any particular muscle, because the muscles they become more prominent in activity than at rest. So it is always advised to ask the patient to perform active movements. Sometimes the resisted movements they make more prominence of the muscle, and it helps you to differentiate between different structures. So in the movement of abduction, the middle fibers can be seen activating, and they can be very easily palpated. The upper trapezius can be palpated by asking the patient to perform either the same side neck bending or the shoulder elevation, and you can see the upper fibers of the deltoid, the origin of the deltoid, the trapezius, sorry, the origin of trapezius and insertion of trapezius can be seen. So ask the patient to try to elevate the shoulders or extend the neck. So one way or another, you can easily palpate. This is the superficial most muscle in the cervical region, and the shoulder region, so you can easily palpate it. The middle trapezius, they can be palpated against resisted movement, and they are just proximal or in line with the infraspinatus muscle. The lower trapezius, this is the movement, or this is the strengthening movement also for the lower trapezius fibers. You need to elevate the shoulder into about 160 degrees, and then you ask the patient to perform extension of the further flexion of the shoulder. You need to resist this movement, and while the patient is trying to perform the movement, it can be an isometric contraction, and then you can easily palpate the lower fibers of the trapezius. So when do you use your trapezius? Okay, not you, but when your Tour de France cyclist extend his neck over his handlebars of his bike, holding a cell phone between your shoulder and ear, carrying articles strapped across the shoulder, and pulling shoulders posteriorly in a military fashion. This is when you use your upper trapezius. Latissimus dorsi and teres major. These are the muscles. They are the broadest muscles of the back. The teres major is called the lats later helper, but because it helps the latissimus dorsi, and it is a complete synergist with the latissimus dorsi. It helps in extension as well, and so many other movements. You can see the massive origination of this latissimus dorsi, and the thoracolumbar aponeurosis, or sometimes referred to as the thoracodorsal fascia, is continuous with this. This is the teres major muscle. So you may ask the patient to resist the shoulder extension and the movement in which the patient or the person takes the hand behind their back. So this is also referred to as the handcuff muscle, because this is the very same position. Hands behind the back is because of the latissimus dorsi and teres major. This is the black is all the origin, and the red is the insertion of the latissimus dorsi. Clearly see the origin of the teres major and the insertion of the teres major. So when you use your latissimus and teres major, steering a kayak with a paddle, it's a small boat, unzipping the back of your dress, walking with crutches, and climbing up a rope with storming a castle. This is the movement that you need to resist, and then you can find the latissimus dorsi and the teres major as well. This is another position in which you can ask your patient to perform shoulder extension from fully flexed position, and on the lateral border of the scapula, just lateral to the or inferior to the lateral border of the scapula, you can find the contracting latissimus dorsi muscle. Teres major is a small muscle as compared to the latissimus dorsi, and it lies a bit deep to the latissimus dorsi. So you ask your partner to perform a medial rotation, and then you resist the medial rotation in prone position, and it makes the teres major a bit prominent. Here you can again see the activating fibers of teres major, and they become more prominent when you are resisting them. The rotator cuff muscles, there are 4 muscles that are called as the rotator cuff, the supraspinatus, the infraspinatus, teres minor, and subscapularis. These 4 muscles are called the rotator cuff because they cause most of the rotation. They are in continuous with the joint capsule of the shoulder joint or the glenohumeral joint, and they are the active stabilizers of the shoulder joint. And in patients having shoulder instability, these are the muscles that you work on and to develop some sort of stability. So the supraspinous fossa holds the supraspinatus, the infraspinous fossa holds the infraspinatus, the teres minor is just lateral to the just medial to the lateral border of the scapula, and the subscapularis is in the subscapular fossa of the scapula. these are the origins and insertions of the supraspinatus, infraspinatus and teres minor, and this is for the subscapularis. Over here you can see all these muscles, they are making the rotator cuff. Cuff is a sleeve-like structure that is formed by the conjoined tendons of the rotator cuff. There is only one structure that passes through this rotator sleeve, and that is the long head of the bicep. You need to remember that just the long head of the bicep pierces this rotator sleeve or rotator cuff. Other than that, there is no structure that passes through it. So these are a few movements when you use your rotator cuff, like for example supraspinatus, conducting an orchestra or installing ceiling tiles overhead. When you are using infraspinatus or teres minor, when you are starting a pull cord lawn mower, or you are pulling a string of a generator, fanning a smoke filled room with your hands or with your arms, and subscapularis, reaching your hand around to scratch your back, and clutching trail guide to the body to your chest. This is the name of the book. Over here you can see the supraspinatus muscle. The patient is trying to abduct, and with this isometric contraction, there is a bit of debate. Some people say that the first 15 degree of the abduction is performed by the trapezius, and then the supraspinatus comes into play. But a few studies have also established that the supraspinatus is functional throughout the shoulder abduction. Then we have this infraspinatus muscle. The patient is trying to horizontally extend the shoulder, and then you can or horizontally abduct the shoulder, and then you can feel the contracting infraspinatus muscle. The movement of internal and external rotation can help you differentiate between teres major and minor. Subscapularis is again a bit hard to palpate because of this key position. This position is very proximal to the chest and very close to the chest thoracic cavity, and it is towards the underside, so sometimes it is not very readily accessible, but in slim and in very lean patients or subjects, you can easily go or slide through this area. This is another position in which you can palpate the subscapular fossa. The subscapular fossa can be felt for or palpated for the subscapular muscle as well. This is how the rotator cuff tendons are present on the head of the humerus. And as I mentioned earlier, that the bicipital groove holds the long head of bicep, and this is the only structure that passes through the rotator cuff. Over here you can see the acromion, the coracoid process, and the tendon of the supraspinatus. This is very easily palpable. This is a position in which it is called the resting position or hand behind the back, and sometimes it is referred to as modified cross position. So in this cross position, when the hand is behind the back, it exposes the supraspinatus tendon and it moves the tendon towards anterior side, and then it becomes more accessible as compared to the neutral shoulder position. Infraspinatus and teres minor tendons, they can be palpated very easily close to the lateral border of the humeral head, and they can also be palpated with horizontal abduction. You ask your partner to perform horizontal abduction, and you can easily feel the tensing muscles. These are the rhomboids muscle, the rhomboid major muscle. It originates from the medial part of the spine, the spinous process, and it attaches or inserts onto the medial border of the scapula. And this is the rhomboid minor muscle. It lies superior to the rhomboid major muscle. These are very flat muscle, thin sheet-like muscles. Sometimes they are not very easily accessible, and it is very hard to palpate these muscles as well. But in this region, clinically, these muscles they become very weak, and they are the cause of persistent scapular pain. So you need to palpate this region, especially the region that is proximal to the superior angle and the medial border, or you can say about two-thirds of the medial border. Lower two-thirds of the medial border of the scapula is very important clinically. Here you can see different fibers, their orientations, and for example, you can see these straight lines. They are the erector spinae group of muscles, and this is the upper trapezius, and these are the muscles which are the rhomboids major and minor. Again, your partner is placing their hand behind the back, and then you need to resist to feel the tension. And sometime when you are moving in this direction, the medial border becomes elevated and it makes the muscles more visible. The levator scapulae muscle is responsible for uneven shoulders clinically. So if you see a patient having elevated shoulder, so this is the only muscle that is pathological most of the time. But sometimes the upper trapezius can also contribute. But this is very important muscle, and it can, trust me, it can totally destroy or disturbs the biomechanics of the shoulder region or the shoulder girdle. So it can influence the scapulothoracic motion as well as the glenohumeral motion, and it can disturb the scapulothoracic rhythm and the glenohumeral rhythm as well. So clinically, you need to find this muscle and you need to treat this muscle for sure, because this muscle is a bit deep, or this is in the second layer of the muscle. The first layer of the muscle is the upper trapezius, and the second layer of the muscle is levator scapulae. Luckily, when you approach the patient's neck, this region is called the triangle of the neck. So in the upper triangle, you can find the levator scapulae, part of the levator scapulae in the upper triangle. So this is the origin and this is the insertion. So it can elevate the shoulder or it can side bend your neck. So you need to resist the shoulder elevation or neck side bending to make the muscle more prominent. Over here, this is the standard procedure. You need to rotate the head to about 45-degree away towards the opposite side, and then you can palpate for the horizontal fibers that comes very superficial, and they are the fibers. They are the cord-like fibers, and you can palpate the levator scapulae. The serratus anterior muscle, as I mentioned earlier, if you ask your patient or partner to take a deep breath or forceful inspiration, these muscles they become very prominent. Here you can see the origin and insertion of the serratus anterior and these finger-like projections of the serratus anterior as well. And they are embedded onto the ribs and they are embedded with the external oblique and the pectoralis muscle as well. This is also called as the punching muscle. So ask your partner to make a fist and try to punch against your hand, and then you can also feel the contracting serratus anterior muscle. While if somebody is having COPD or if somebody is having labored breathing, with every single inspiration you can clearly see the serratus working. So doing a push-up, throwing a punch, or pushing open a swinging door, then you're using your serratus anterior muscle. The pectoral muscles are very easy to palpate because they make the bulk of the muscle. This is again one of the important site of anterior chest pain. It mimics the pain of angina If there is somebody who is having the anterior chest pain, often it is radiated to the upper extremity as well, so it really mimics the angina. So the pectoral pain can be sometimes very confusing with angina, so you need to palpate this region. So here you can see the clavicular fibers, the sternal fibers, and the costal fibers of the pectoralis major. The pectoralis minor is underneath the pectoralis major, so pectoralis major is making the bulk of the pectoral region. This whole part is the origin and this part is the insertion. If you want to palpate the pectoral in female, and it's really very comfortable to move the mammary region away or the breast away, and then with your dorsum of your hand, and then you can drape the patient and palpate. This other position, the sideline position, because of gravity, it helps you to clear this chest area, and then you can easily palpate for the pectoralis major muscle. Pectoralis major is a very strong shoulder adductor and a medial rotator, so you can perform a resisted contraction or isometric contraction of medial rotation, and you can feel the tensing pectoralis major muscle. Here you can see the shoulder adduction can be resisted, and it also tenses the middle fiber or the lower fibers of the pectoralis major. The pectoralis minor is a small muscle. It is also attaching to the coracoid process. It also helps in respiration or inspiration. It is also an accessory muscle, and it also stabilizes the scapula as well. You can see the origin, the third, fourth, and fifth rib, and the coracoid. These are important to remember that there is a condition called as thoracic outlet syndrome. So the first part of the subclavian, the second part and third part of the subclavian artery, there are three parts clinically divided into the first, second, and third part. So sometime the pectoralis minor muscle becomes tight, and if it becomes tight, it can compress the neurovascular bundle, the nerves passing over here. So it can cause thoracic outlet syndrome. It can cause the radicular pain in the upper extremity, sometimes the bluish discoloration, and there are a lot of tests that you can perform to differentiate between the thoracic outlet syndrome and other clinical conditions. So because this muscle can elevate the ribs or it can depress the shoulder, so shoulder depression can be resisted to feel for the contracting fibers of the pectoralis minor muscle. Bicep brachii, it has two heads, the short head and the long head, already discussed. It has a conjoined aponeurosis which insert onto the ulna, and some part is inserted onto the radius as well. So the long head, the short head, you can see the long head passing through the basipital groove, attaching to the supraglenoid tubercle, the short head attaching to the coracoid process. You can ask your partner to perform elbow flexion in mid supinated position, so that helps you differentiate the bicep. Tricep brachii, it has three bellies, the long head, the medial head which is the smallest one, and then the lateral head, and it has a very long this aponeurosis or tendon like process. So the medial head is attaching directly onto the humerus, while the long head is attaching to the lateral border of the scapula. And it is inserted onto the olecranon process, which is part of the ulna, and it is a very important shoulder extensor as well as elbow extensor. The tricep is easy to palpate. You can resist elbow extension in this position, and you can clearly differentiate the fibers of tricep brachii. This is the only elbow extensor, and here you can see that this tricep The long head, it is sandwiched between the teres minor and teres major. So it slides under the teres minor and teres major. Coracobrachialis, it is again a very important muscle, but a short muscle because it originates from the coracoid and insert onto the humerus. Now, your partners in supine position, you can palpate coracobrachialis as your partner horizontally adducts against your resistance, and it is medial to the bicep muscle. Other few structures you can see again the neurovascular bundle, the median nerve, the brachial artery passing through this region. It can be compressed against the humeral shaft, and then you can also see the basilic vein and similar structure like ulnar nerve and other structures. The brachial artery, again, this region is important clinically because you can feel for the brachial pulse over here, and you can also apply pressure if there is bleeding distal to the site. So this is the reference book. Thank you very much for staying with me and listening to me. I will take your questions and answers once we done with the recording. Thank you very much.